Thanks everybody for tuning in. We're going to go through a number of important issues. As Grisha said, this is an area that is top of mind for everyone, professionally, personally, family, all sorts of issues, and lots is changing. And this is we've been on these town halls before, and many of us do um, uh, versions of this type of information for a number of our clients, and every time we do it, something has changed within the last 24 hours as we prepare for it, and certainly that's happened. That continues to happen here. So clearly a challenging environment, and all the things that we've said in the prior town halls about being vigilant and being nimble and paying attention to your mental health and your family's mental health and your well-being are all very important to remember. I'm going to be joined today by my colleagues, Dr. Michael Anderson, who you've all heard from, who will discuss some issues particularly related to schools and kids. But first, I'm going to turn it over to Dr. Emily Lankau, who is going to work through and discuss a lot of the data and the current situation, give us a situational update. She does this for many of our clients, and we're happy to have her do it for you today. So Emily, I'll turn it over to you.
Thanks, Till. Can you hear me okay?
Yes, you're there.
Fabulous. So while I get my screen set up to share, I'm going to invite everyone to take a really deep breath because we're going to look at some very difficult, complex data. And as Till said, our mental health when going through this is really important. This is tough for the data team, and it's probably going to be tough to look at today. So what you should see now is a map of the globe. We're looking at Our World in Data, which is one of our resources we use with our clients to look at what's going on internationally. And I'm going to start at the international picture and kind of drill us down to what's going on at a county level across the country. The international picture is really very spotty right now. We were at a better place for a period of time after coming down from those big peaks in December and January. But with Delta virus taking off in March and April, we've seen a global resurgence of COVID virus transmission. Particular areas to note are the UK, Spain, and some other areas of Europe that have very high case counts. And the US has been rising lately, so we're going back up to an area that we wouldn't like to see. I'm going to show you just a couple of countries so you can see these timelines. And the thing that we're really concerned about right now is that right now the United States has a curve that looks an awful lot like what the United Kingdom looked like in early June. The United Kingdom has taken off with Delta virus predominantly. That's the variant they're seeing. And they are seeing pretty high case counts at this point in time. Similar story in Spain. So the United States is at a pivotal point where we really all need to continue to double down on prevention and vaccination because this new variant is highly infectious and has been spreading rapidly across the country. I want to give you a sense of what vaccination looks like globally and how that compares to what we're seeing in terms of viruses. So hopefully this is working. You can see two screens side by side now. And we have a map of the United States on the left that shows our case rates, or sorry, of the nation of the globe that shows case rates, and then a map that shows vaccination rates. And so again, light colors over here means low case counts, dark colors means not so good. And on the vaccination rates, it's just the opposite. So light colors mean not great vaccination rates, dark colors mean we're doing better. And the thing I want you to note is that we have really heterogeneous distribution of vaccination across the globe. There are some countries that have quite high vaccination rates, Canada, parts of Europe, the United States, but we have other areas that are really working hard to get vaccines distributed and are not at those high rates yet. The other important pattern I want you to see is that even in places like the UK and Canada that have high vaccination rates, we are seeing an emergence of fairly high case rates because of highly infectious variants. So vaccination works and it is helping, and it's not the only thing that protects us from this virus because we're not there yet. I'm going to go back over to one screen and we're going to show you what's happening in the United States right now. This is another map that we tend to use with our clients. This is COVID Case Mapper. It's run by big local news and the New York Times data repository. And I know folks monitor this, so you know that we have big hotspots in our country, particularly along the Mississippi Delta area where we're seeing Missouri, Arkansas, Louisiana, and then across the Gulf Coast, seeing these southern states and Florida popping up as big hotspots. We do like to give you good news too. The good news is we are seeing locations that have come down from high peaks up on the East Coast and in the upper Midwest that are currently maintaining those standards. And a lot of that is because of vaccination. So we're going to scroll back over here and show you two maps side by side to give you a picture of what's happening. If we look at the national picture by state, we see that we have a lot of heterogeneity in our vaccine distribution by state as well. And you'll notice that these light colored states that have low vaccination are aligning with these areas that we're seeing a lot of cases popping up in hotspots. The picture gets even more complicated when we look at it from a county level. So if we pull this up at a county level, we see that even in states that are doing quite well, we're seeing variability from county to county in terms of vaccination rates. And that means that even states that have high vaccination rates have vulnerabilities in those counties that have lower vaccination rates. The one I typically point out because I live here, Dane County here in the middle of Wisconsin, we have very high vaccination rates. It's a university town, mostly hospital employees. And so my county is doing really well in terms of vaccination. But neighboring counties, even in Wisconsin, have much lower rates, for example, in Waushara County, or if we head up north to Taylor County. So while Wisconsin is one of our higher vaccination states, we still are vulnerable to this virus if it continues to spread. The next thing I want to show you is looking at the local level because we're seeing really different patterns across the country. And I'm going to focus in on Missouri, and then I'm going to take you over and look at the DC area since that's a place we have a lot of employees. What you should see now is Taney County in Missouri, and we're going to scroll down and show you all of Missouri. Taney County is one of the big hotspots we're seeing right now, and you'll notice just how low vaccination rates are in that area. In Taney County, we're talking 26% fully vaccinated, and Taney County is one of our hottest counties in the country right now. So there is a big alignment here with vaccination rates and infection rates. If we look on the other side of the country, at Maryland in the DC area, we see very different patterns. So in the DC area, we have much higher vaccination rates, and at least presently, they have been maintaining much lower case rates overall in the DC area. Right now, Maryland is running at 27 per 100,000 14-day case rate, which is closer to what we'd like to see, and their vaccination rates are also quite high. So there is a correlation. But I want you to note that even in Maryland, we do have some counties with lower rates that are vulnerabilities for virus spread. So this is a troubling story, right? We're seeing an awful lot of case rate increases. We're seeing a lot of concern about the Delta variant. And the reason for that is because the story really is becoming fairly clear. This map is one of my favorites someone put together. 40% of residents fully vaccinated and also have 100 new cases of COVID per 100,000 residents over the past week. And you'll see those hotspots that I highlighted are bright orange because those are the places that are the most vulnerable in our country right now in terms of both virus spread and protection of people because of vaccination rates. So a little bit on Delta variant. Delta variant is much more infectious than our original Wuhan virus. So this is a lovely figure that Arnold Bogus sent out to the team that I've used a lot. And what we saw originally is maybe 2 people would get infected per case. Newer variants emerged that were more infectious, and then Alpha variant emerged from the UK, which was even more infectious, and Delta variant is even more infectious. So every 1 case has the potential to spread to 5 to 8 people, because this virus is just much better at getting from person to person than the original variant. And what we're seeing in the United States right now, give my map a second to update here. What we're seeing is an increase in the percentage of variants that are sequenced that are this particular variant. So if we look back in April, our dominant variant was the UK variant that originated in the UK, the Alpha variant. Right now, what we're seeing is 83% of sequenced viruses are coming back as the Delta variant, and that has risen very quickly from the first detection in March until now. And that is true across the country. So this dark orange here is that Delta variant, and we're seeing it in rising numbers across the nation and particularly in the middle of the country where we're seeing those hotspots. I don't like to end with a bad news story, so there's good news and bad news in this update. And one of the really good pieces of news is that we've made a lot of progress in protecting people from severe disease and death because of vaccination. So I'll just give you the example of the changes we've seen based on age. So throughout this outbreak, we've seen that people who are 65 and older have been kind of in the middle of the pack in terms of total number of cases, right? So if we look at this in the peak outbreak, those purple lines, the dark purple line is our 75 plus, they had similar rates to everyone else in terms of age groups. But the scary thing that we've seen through this outbreak is that people 65 and older have been the majority of the deaths. And so they had death rates that were up to 100 times what we were seeing in younger age classes earlier in this outbreak. And the good news story is vaccination does work to protect people. And so if we scroll in a little tighter here, we see that we've seen dramatic declines in deaths in those populations of older persons. And now we're seeing death rates that are much more similar to what we're seeing in our younger populations. And that is predominantly because people 65 and older are at a 70% vaccination rate relative to some of these younger populations who are still getting vaccinated. So the take-home message here is we're at a very tenuous time and things are really variable across the country. And the best thing we can all do is get vaccinated. That is one piece of the Swiss cheese model we can all control for ourselves and our families. And we should also adhere to all the public health practices to avoid respiratory diseases generally. Not only are we seeing COVID case counts going up, but in some parts of the country, other respiratory diseases have reemerged as we've come out of our seclusion. And those viruses also cause significant illness in some populations. So we're going to turn you back to the Swiss cheese model. We're not out of this yet, but we've made a lot of progress. And so we need to continue doubling down to protect those who have not yet had the chance to get vaccinated. And with that, I will turn it back to you, Till.
Thank you, Emily. Lots of data, and I'm struck. As I think through this, we talk about this a lot with folks and with non-scientific audiences. You folks are quite a scientific audience, but not necessarily health. You probably didn't know that a variant existed about a year and a half ago, and now you're able to speak that language. So we want to make sure that everybody understands what's going on, and we'll certainly take some questions. So thanks for that great presentation, Emily. And there's a question about sharing the dashboard site. Certainly she can do that. These are sites that we commonly work through and share with our clients.
I'll send them out to Carissa.
Great, thank you. And we'll answer other questions later. Now I'm going to turn, I see you there, Dr. Michael Anderson, who's working very hard on a number of issues within ASPR, and as you know, is a pediatric intensivist, really with a vast expertise. And so he's going to talk through a collection of issues related to children and others who are important to us from his perspective. And then I'll go through a few issues and then we'll do a Q&A. So Mike, take it away.
Thanks, Till. Can you see my slides and hear me okay?
Yes, you're there and I can hear you.
Great, thanks. Good afternoon, everybody. Emily is always such a difficult presenter to follow because her presentations are always spot on. And as she said, concerning data, and it's a concerning time. And all the work that we're doing in public health, I think, is now more important than ever before. So I am a pediatrician. I'm a pediatric intensive care doc. But most importantly, I'm a father and a grandfather, and kids remain a really important topic for us to think about and for us to strategize around how we can support them. A couple of breaking news, as Emily said, things change, and her terrific use of websites show that this changes on a regular basis. This is only about 48 hours old, and this is how are we going to get kids back to school safely. Obviously, the EUA approved vaccines have not been approved yet for kids under 12. There's some debate, which I'll go into in a slide or two from now. So how do we get kids back in school safely? In the American Academy of Pediatrics, the AAP, just came out with a statement 2 days ago that said, first and foremost, we've got to do everything we can to get kids back in person in school. It is not just the quality of the education, and God bless all those parents and grandparents that became part-time or full-time teachers over the past year and a half, but we know that kids develop more appropriately and at a better pace if they're with other kids, and if they're learning how to socialize, they're learning how to handle bullies and how to be part of a social milieu, if you will. We also know there's many kids across this country who have support systems available when they're in person in school that they don't have as available when they're not in school. So number one, the American Academy of Pediatrics says that parents and advocacy groups and school boards, we've got to work together to make sure we can get kids back in school. The second is, how do we do that safely? And of course, the AAP has been advocating for the safe administration of vaccines to kids under 12, but they also came up with something that is unfortunately a little controversial, and that is recommending that kids go back to school with masks no matter what their vaccination status is. In other words, a 13-year-old, if they're in a close quarters, they're recommending masking. They say just because of the great data that Emily showed, the variants are more and more transmissible. We don't want kids bringing this virus home to potentially unvaccinated adults or kids. And thus the AAP came out with saying, you know what, if you're in a closed space, then you should be wearing a mask, but let's get kids back into school safely. I don't have to tell you all, a very educated audience, it's still so political out there. A little sidebar story, I have one of my former fellows that was supposed to do a television interview about getting back to school safely and the American Academy of Pediatrics recommendations. And I won't say what state she's in, but her hospital media department canceled the interview because the AAP recommendations were so politically charged that they didn't want their hospital associated with this interview. It's really sad and concerning that we have to both fight the virus and fight the political tension in this country still. But of course, we unfortunately are still well off of that. So AAP is recommending in person, work hard towards it, but kids should be masked. They're also saying that, by the way, we've got other things to do to make sure that kids in school have equitable educational support, that we make sure that all kids have educational programs. So I love the AAP because it's not only advocating for important public health stuff, it's also saying, by the way, our kids have been through the ringer, just like everybody in the world has. I get that. But our kids have really been through the ringer. Let's realize as kids go back to school, and Emily and I have commented before on the mental health crisis in kids, let's make sure that kids have all the resources they need as they go back to school. Just briefly on vaccine, as I said, the EUA approved vaccines are indeed approved for kids over 12. We know that 2 drug companies, Pfizer and Moderna, are studying the vaccine in kids less than age 12. But I have seen nothing in the lay press or in the medical literature as to when is that vaccine going to become available for potentially down to 6 months of age. This has led to an interesting debate. Most pediatricians saying, just like measles, just like mumps, just like varicella, we need to vaccinate kids because kids have died from this disease. Kids can transmit this disease in their family, and the variants make us very nervous that we've got to contain or stamp out this virus by vaccinating as many people as possible. But just like every other debate around COVID-19, there's still some camps saying, well, why would we want to vaccinate kids? Let's not experiment with them. I, as a pediatrician and an academic researcher for kids, can assure you that when we bring out vaccine for kids, it will have been studied, it will be monitored by the FDA, but suffice it to say there's no timeline right now on when we're going to get a vaccine for kids under 12. Emily did a great job on this. I will suffice it to say that her maps of vaccinated and unvaccinated are really kind of concerning, and each of those hotspots she highlighted, my daytime job with ASPR, we've been on many phone calls with these state health officials, and I just must share the emotion in their voices when they realize that 15 months into this, we're now in for round 3 of this fight where they're seeing their hospitals start to surge and they're seeing more and more patients that are sick, and there's just heartbreak in their voice because they know there's some very entrenched parts of this country that for so many fascinating and horrible reasons won't take the vaccine, and they're just fighting such an uphill battle, and it's sometimes, quite frankly, heartbreaking to be on those calls. What I will say, and this is my day job with the federal COVID response, is the monoclonal antibodies, the 3 EUA approved monoclonals, and that's for early symptomatic patients that aren't sick enough to be hospitalized. more and more of the data is showing about a 70 to 80% decrease in the need for hospitalization. A patient turns positive, they're not sick enough to be admitted, they're within the first 10 days of symptoms. These monoclonal antibodies, once again, 3 EUA approved monoclonals, are really doing amazing work to decrease hospitalization. But this same mistrust in science, the same mistrust in organized medicine and the federal government is unfortunately percolating into making sometimes getting these therapies into patients an uphill battle. But I'm very proud to work for Aveshka and then work for ASPR at trying to get these therapies into many patients as possible. Emily and I didn't rehearse this. I'm very glad that she started her talk saying, let's take a deep breath and realize there's a lot going on. I think we have to acknowledge there's COVID fatigue. We're all tired of this. We would love this to all be over, and I'm not on the front lines in the intensive care anymore like I was for 20 years, but the healthcare system is just beat up. However, there's still thousands and thousands of patients that are going to need us to stay strong, to keep getting the word out about vaccine, to make sure these monoclonals are in as many patients as possible. I think it's going to be a long fall and winter, but I'm very proud to work for Aveshka, to work on this public health crisis. And with that, Till, I will end my formal remarks.
Thanks, Mike. And that's very important remarks, and they're going to be a lot. I've already seen some questions that we're going to turn to you for a couple of kid issues coming up. So thanks for that. What I'm going to do now is just cover a couple of other issues without slides, and then we'll go to Q&A. Just very quickly, some questions that we've been asked in advance, and also some questions we get from various of our clients when we interact with them. I did a town hall for one of them yesterday and got a number of these types of questions. So the first issue is really boosters, and you know, as I've said to many of our friends and colleagues and our clients, boosters are an important subject. But what we really need to do now is get people vaccinated the first time, the ones that are eligible, at least from 12 and older. We'll talk about the timeline for others later, but we've got a lot of work to do on primary vaccination. So, but boosters will likely happen. We don't really know the timeline. You look all over for scientific data. We know that, and we've talked about this for months now, that this is a likelihood, and realize that scientifically the first people who got vaccinated have only really been vaccinated for about a year, and they're the experimental group. And the first mass group of people who got vaccinated started in December. And so people have not had this vaccine in their body for all that long. So far, we don't have, even though there are breakthrough cases, that's a different issue. We don't have any evidence that the immunity is really waning from these boosters. And so there are two basic ways to measure that. One is just measuring antibody levels, although antibodies are not the only source of immunity in the human body. But when antibody levels are measurable, we're not totally sure what the measurements mean, but we can measure those, and then we can look at increases in cases and severity among those who are vaccinated. And this is a subject of great investigation. We don't have any particular findings from this at this point, but certainly in places where there are large populations that have been vaccinated, this is being followed. And the manufacturers are certainly looking at this, as is the FDA and the CDC. There are a number of possibilities for what could happen, and we get specific questions about this because of various anecdotal reports. One thing is, could you just be another dose of the same vaccine? You had Pfizer, you had Moderna, you had J&J, you get another dose of that vaccine. Or perhaps more likely than that, another dose of an adjusted vaccine, because we talk about the Delta variant and now the Lambda variant, which is going through parts of South America, and others that may come. The manufacturers are looking at how to make the vaccine more specific to those variants. So it may well be an adjusted vaccine of the same type. One could also give a dose of a different vaccine. We've seen news stories about maybe the J&J vaccine and then being followed up with Pfizer or some combination like that. We don't know the science on that, but that's entirely possible that could be of benefit. And then the CDC, I believe, is meeting on this week. There's a question of earlier boosters for those at higher risk. We know scientifically that the immune system is a continuum. It's not a sort of an on-off switch. And so we know that some people, either because of age or something inherent in their body, some sort of process, or something we do to them as physicians, like immunosuppressing them because they're cancer patients or transplant patients. There are reasons why people's immune systems are not as strong, and so perhaps those people may need boosters earlier than the general population. All this is still being investigated, but we are going to have a messaging issue and things to talk about related to boosters. So there'll be more to come, and this is certainly not our last town hall because this will come up. One other issue just to bring up briefly, and others may have comments, and others outside the public health team may have comments about this, is issues in the workplace. And this is something that we are working with our clients on a daily basis. First, related to vaccines. Some employers are mandating vaccines, and we know that under certain versions of employer health law, employment health law, that is possible. We've seen controversies in certain places, some hospitals with workers fighting back against that. A recent court decision in Indiana supported the Indiana University mandating vaccines for its students. So lots of news about this. But one thing, is important in the messaging for this is as we get back into the workplace, either in an Aveshka office or another office we may visit, it's important not to really inquire about people's vaccine status. It's a private issue. There may be a natural inclination to ask. And then remember that masks, currently the general guidance in most places is that masks are primarily needed are required for the unvaccinated and optional for the vaccinated, but it's something of an honor system. But you can't assume that somebody who's wearing a mask is unvaccinated, because many vaccinated people, particularly with Delta variant and other concerns, are now masking, and we're seeing jurisdictions that are suggesting indoor masking again. So really, you can't assume things based on what you see. We're seeing news about travel, and we're seeing news about masking in indoor environments. This is likely to change, and many public health experts now are starting to say, you hear the AAP saying it about schools, many experts are starting to say, you know what, maybe a good idea to go back to wearing a mask in an indoor environment because of the Delta variant and the factors therein. And remember family safety. Those people have families at home who have health conditions, and they may need to be more careful in an environment outside the home in order to protect those inside the home. So lots of issues there, and lots of things that everybody struggles with. And as we know, we've discussed this internally at Aveshka, but many of you have spouses and partners and friends who maybe work in other places, and their workplaces are probably having some of the same issues. And many of our clients are struggling with this because, as with anything, there's nothing terribly certain in this, and this is a changing environment. So lots of things to struggle with. So I'm going to stop there. We have a few minutes, a lot of information there to unpack. But Chris, I'm going to turn it back to you, and perhaps you can lead us through a few questions.
Okay. The first question is what is the demographic of people that are choosing not to get vaccinated?
Yeah, that's an interesting question, and I'll address that a bit. It's variable, and so there are, as we look at this, there are demographics related to age, which is interesting. I mean, we really went after the older age groups first, and so we have a very high uptake among our older population because they were very aggressively gone after first. And then we have challenges in the younger age group, as we see in the adolescent, in the late adolescent and young adult age groups. We have lower uptake. Some of them, they may think they don't need it. They may think they're invincible, and so we're facing challenges there. And we may well face challenges in the younger age group. So we certainly see. And some of the contribution of the lower hospitalization is in getting those older folks immunized. So it was a pretty successful campaign. We're worried about the lower age groups. As far as other issues, we do see higher uptake among white populations versus Black and Hispanic populations. That's kind of a generalization that, of course, has local variability. And we've heard about sort of the political issue, and you can't really ignore it. I'm not going to talk about politics here, but we certainly see states that tend toward red as we talk about them. Although it's not like the map is red and blue. I mean, there's variability even within states, but we certainly see localities with certain voting patterns that seem to have lower vaccination rates. And if you look at sort of the Kaiser Family Foundation to survey people on why they didn't get it, one was side effects, which people don't want to deal with the side effects either because they don't want to deal with them or they don't want to be out of work for a day because of them, which is a legitimate concern for many people who sort of are very living on the edge. And then people saying that it's too new and unknown and not tested enough. And some of that will overcome and some of it we won't. Next question.
Okay. We know that the Delta variant is more transmissible. Is it more virulent?
Mike, I may have you ask you to address that if you can.
Yes, so far it does not appear to be more virulent. However, it's still not a good story because this virus can wreak havoc in even the healthiest of patients with bad pulmonary complications, really weird complex thrombosis complications, and then those rare but really heartbreaking cases of long COVID. So it doesn't appear to be a quote unquote worse clinical course yet. But this is a bad virus, and period. You don't want to get it. This isn't the flu. This isn't a cold. So thank God it doesn't appear to have a higher mortality or morbidity rate. But this is still a bad virus. Period.
Okay. What do you say to parents who refuse to believe in the vaccines that masking is causing mental illnesses in their children, and in one case, that's not the responsibility of one child to keep another child safe? What do you do?
I thank God that I'm not a general pediatrician having to deal with these heartbreaking issues every day. It's really tough. It is. Even before the pandemic, and I have a lot of dear friends that are general pediatricians from my residency days, there's a vaccine hesitancy baseline, right? I mean, there's a strong, unfortunate anti-vax. You then add on all the politics that Emily and Till talked about. It's really, really tough. I do think I would disagree that I think we are in this together. That's not just a marketing slogan. We need to keep each other safe. Number two is there have been incredible challenges with this virus, but masking doesn't cause your CO2 to go dangerously up. It does not cause mental illness. And if your kids are stressed about it, then that's an opportunity to talk to your child about public health safety issues. So I once again thank God that I don't have to do this each and every day, because family medicine docs and nurse practitioners and pediatricians are really on the front line of helping us get this under control.
Next question is, how concerned should parents be that their kids under 12 might contract and suffer from the Delta variant?
It's concerning, but not overwhelming. Once again, the good news is probably due to decreased number of ACE receptors in a child, that kids don't have as bad a disease. However, that doesn't mean that you shouldn't do all the non-pharmaceutical intervention, the NPIs. Good hand washing is terrific. I think the mask AAP mandate is a really good idea. And I think once there is a vaccine for kids under 12, then I think that's a chance for parents to get their kids vaccinated. So it's concerning. I also think it continue. We want to get back to normal, right? We want to go to the movies and we want to do big activities. But I think there's also a level of common sense that still has to be undertaken. And I live in DC. There's no DC mandate. I think Till alluded to this. I still wear my mask indoors, even fully vaccinated, just because I know it's a long time period ahead until we get these variants under control.
As a follow-up on that, for children that are under 12 and that vaccine hesitancy, I think you or Till might have mentioned that there's some concerns that it's not been approved. Is there a reason why? Like, why is that? Why has that vaccine not been approved for children under the 12?
So number one, there's just not data. So when the pharmaceutical industry got EUA, emergency use authorization, they just studied down to age 12. So kids between 6 months and 12 are now being studied. And I know that Children's National here in town is a part of those studies. But that's actually, it's a little bit disconcerting because kids aren't covered yet. But it also means that we're doing it safely, that we're not just going to take an adult dose and sort of, maybe give half of it. and just put it out there. We want to study the safety, the efficacy. There have been very rare, cardiomyopathy complications, heart inflammation in kids. So far, it's a very, and not kids, in patients 12 to older. That's been a very, 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 very small amount, and the CDC and FDA are monitoring it. So the bottom line is it just hasn't been studied in kids younger.
What are the updates on long haul outlook for COVID?
I'll let my adult colleague Till talk about
that. Yeah, thank you. This is a tough issue that is still being worked out. We don't even have great diagnostic criteria for what is long haul COVID. We do know that there's a subset of the population that do have long-term symptoms. It's a combination of, some of them have long-term pulmonary symptoms. Their respiratory systems just don't work that well. And many of them have had these clotting problems that cause pulmonary emboli and strokes and otherwise while they had them. And then others are having neurologic problems, and COVID fog and other terms were applied to this, and they still exist. So folks that aren't quite all, they're not as sharp, they don't have the concentration ability they had before. It is a real issue. But it's interesting from a clinical standpoint, there's no one person to go to, no one specialist to go to deal with long haul COVID. It's neurologic, it's psychiatric, it's pulmonary, it's on hematology. But it is a real threat, and it is, even if you do well and survive the acute illness, to be stuck with long haul COVID because you chose not to be vaccinated is a real issue. Chris, you're on mute.
I think we have time for one more question. It says, there are some rumors that some of the research and development that have already found issues with the vaccine impacting reproductive systems and fertility. Can you comment on that?
Yeah, this is a lot. Thank you for bringing that up. I mean, this is a rumor that went around, within, I think, days of the first experimental vaccine that was going out, and they keep manifesting themselves. There's no evidence for this at all. So, it's something that sort of needs to be followed, but there's really no evidence that there's any significant impact on the reproductive system. And the bottom line of the vaccine is it's protective to you and protective to those of your family, and recommended. It's another of these things that we're going to have to keep answering because it just keeps coming out. You can't completely ignore the question, but there's no real evidence to this at this point.
Okay, those are the only questions that I have seen in the chat. So any last comments, Till?
Yeah, this is, I appreciate you and other leadership continuing to bring us forward, because these are important issues, and realize that if you're, plenty of people had questions and didn't ask them. So I very much appreciate the people who did ask them. They're important questions. And I'm available. If somebody's got something they didn't want to ask publicly, I'm certainly available, easy to find, and true of Dr. Lankau and Dr. Anderson and the rest of our team also, because it's important for all of us. It's important for our work lives. It's important for our family lives. And so feel free to contact us if you just got something you don't quite understand and want a little more information. Happy to do it. So with that, I'm going to turn it back to Girish for a few final comments.
Thanks very much. So first of all, I'd like to thank our esteemed colleagues, Dr. Lankau, Dr. Anderson, Dr. Jolly, for giving us the insight, the information that I think is invaluable, and also helping to debunk many of these, false rumors, innuendos that are out there about the vaccine and other things. Again, I encourage each and every one to get vaccinated so that we can come back to as close a normal life as possible. Clearly, at the end of the day, one should consult their doctor, physician for the best advice as it pertains to them. So thank you all again. And we'll continue to have you back, because this unfortunate issue is not going away anywhere. And periodically we will call on you to help educate us in terms of the latest information regarding this. Second of all, again, I want to congratulate the employees that Beth recognized earlier today. Thank you for your outstanding service. We appreciate it very much. And last but not least, I want to thank all of you for taking the time out and participating in this for the last hour or so for the invaluable information. Thank you for your outstanding service and commitment to the company. Good luck, stay safe, stay healthy, and I'm sure we'll be seeing you and talking to you all soon. So thank you all very much. Goodbye.